Cultural and spiritual backgrounds and belief systems can vary widely among clients. Individuals and families might identify with more than one cultural or spiritual group and choose whether to adhere to the traditions, values, and practices for the groups they are connected to. Transcultural nursing involves learning about and comparing cultures to provide care that is sensitive to cultural patterns, beliefs, and values. Spirituality relates to whatever an individual uses or does for self-discovery, coping, and health maintenance. Spirituality is personal and subjective. Culture involves the similarities shared among members of a group that can be transmitted generationally, through heritage, or across groups. These similarities include ways of thinking, like values, norms, beliefs about health and illness, language and communication, and customs, art, dress, and music. Cultural groups can be linked by a common ethnicity, race, nationality, language, religion, location, sexual orientation, class, or gender. Culture influences health beliefs, health practices, and manifestations of, responses to, and treatment of illness or injury. Culture evolves over time and is shared by members of a group who have similar needs and life experiences. In healthcare, it's important to understand other terminology associated with an individual's culture because this could impact their care. Ethnicity is the shared identity, bond, or kinship people feel with their country of birth or place of ancestral age. Ethnicity affects culture. Race has traditionally been linked to biological or genetic traits or shared origin or background. While genetic discoveries have shown that races cannot be identified scientifically, race continues to be used to identify groups of individuals when individuals self-identify on the U.S. Census. Subcultures are developed from a smaller group that share cultural values like ethnicity, occupation, with a larger group. Acculturation occurs when an individual is exposed to a new culture and adopts some of the cultural practices of the predominant group. The individual might adopt the predominant culture and form a new cultural identity through the process of assimilation. Example, the client was born in Central America and has been a resident of New York for 2 years. Multiculturalism is the influence by more than one cultural group, adopting preferences and shared values from more than one origin. The study of culture includes understanding general facts about cultural groups. Avoid stereotyping behavior which assumes that group generalizations are true for everyone in the group. Not good. Cultural assessment and data collection. To meet a client's cultural needs, a nurse should gain knowledge about their own culture and other cultures. This is called cultural awareness. This allows the nurse to have a better understanding of cultures and eliminate and identify any potential bias. Bias can be unconscious or implicit and can impact the delivery of care. Unconscious bias is non-self-controlled judgments that could be influenced by our heritage and personal encounters, and implicit bias is self-awareness of our personal judgments. Cultural assessment data collection involves skills such as interviewing for the health history and physical assessment. The nurse should perform the cultural assessment in a language that is common to both nurse and client or use a facility-approved medical interpreter. Inform the interpreter of questions that might be asked. For the interview or health history, we should use focused, open-ended, non-judgmental questions. We need to listen. We should paraphrase the client's communication to decrease misinterpretations. We should never make assumptions. We should observe and study the client and their environment for examples of cultural relevance. We should establish a therapeutic relationship with the client. This can be hindered by misinterpretations of communication. Nurses should develop transcultural communication skills. As nurses, we should understand that nonverbal behaviors vary among cultures. We need to assess the client's gestures, vocal tones, and inflections. Observing the client's interactions with visitors can provide the nurse cues to the client's nonverbal communication style. We need to be aware of personal nonverbal behaviors and consider how the client might interpret them. Some cultures use a soft tone of voice to convey respect. Some cultures use a loud tone of voice to communicate. Most cultures value direct eye contact as an indication of attentiveness and respect as well as self-confidence. Lack of eye contact can be interpreted as an indication of possible mental illness, guilt, or secrecy. Other cultures, though, consider direct eye contact an invasion of privacy or disrespect. Directing the gaze of the eyes downward toward a client can be interpreted as demonstrating authority. Sitting and looking at the client at the same eye level would be way more respectful. Some cultures are more stoic in their facial expressions, showing few emotions. In others, facial expressions are used as the main way to convey feelings or to hide feelings. The amount of emotion displayed through facial expression can vary depending on how well the client knows the individual with whom they are interacting. Be aware of facial expressions and how the client might interpret them. Cultural values dictate what forms of touch are appropriate. Always ask the client's permission before touching them. Watch to see how the client reacts to touch. Some cultures value a large amount of personal space, while others value closeness. The amount of space acceptable can vary with the type of interaction. Try to mirror the client's use of distance during interactions and get consent from the client before moving close to the body. Some cultures value silence, sometimes for long periods of time. It can indicate respect and agreement and provide privacy for the other individual. In some cultures, interrupting someone else while speaking is acceptable. Posture and gesturing can also vary across cultures. Avoid using hand symbols, a thumbs up or an OK sign, unless you've seen the client make the gesture, as they could be interpreted offensively by the client. In subcultures, an erect posture indicates self-confidence. A more slouched posture could be interpreted as the opposite or as an indication of a physical problem. Observe posture and consider the client's culture before making assumptions. Observe the client's body posture when lying, sitting, and interacting with friends. Patient-centered care. Care should promote health equity or the best health for all individuals and groups. The Learn assessment tool is a common communication tool used to promote culturally competent care. The Learn stands for L for listen actively to the client describing the current problem. Use empathy and try to understand the client's perception. E, explain the healthcare professional's perception of the problem, which can be cultural, psychological, spiritual, or physiological. Acknowledge the differences and similarities between the professionals and client's perceptions. R is recommend treatments, including the client's choices. And N is negotiate with the client to involve medical recommendations and client preference. Culturally responsive nursing care involves the delivery of care that transcends cultural boundaries and considers a client's cultural beliefs as they affect health, illness, and lifestyle. By encouraging client decision-making, the nurse fosters respect and promotes sensitive and effective care. The client's needs are met, and the client is more likely to adhere to the treatment plan. Within the context of culturally responsive nursing care is terminology that describes how nurses approach client cultures. This is important to know. Cultural awareness involves self-awareness for the nurse, examining personal attitudes related to various aspects of culture to identify possible biases. Cultural sensitivity means that nurses are knowledgeable about the cultures prevalent in their area of practice. Cultural appropriateness means that nurses apply their knowledge of a client's culture to their care delivery. Cultural competence means that nurses understand and address the entire cultural context of each client within the realm of the care they deliver. Competence is developed over a lifetime as the nurse continues to attain knowledge and develop cultural skill through varied client encounters. Cultural imposition is like ethnocentrism and occurs when a nurse imposes the rules of their culture onto another person. This is sometimes referred to as cultural blindness. Accommodate each client's cultural beliefs and values whenever possible unless they are in direct conflict with essential health policies. The goal is to provide culturally competent care. When assessing pain, we have to recognize that how clients react to, display, and relieve pain can vary by culture. We can use an alternative to the pain scale because it might not appropriately reflect pain for all cultures. We can also explore religious beliefs that influence the meaning of pain. For nutrition, we want to provide food choices and preparation consistent with cultural beliefs. When possible, we want to allow the client's family or caregiver to bring in food, ensuring that it meets the client's dietary restrictions, and allow clients to consume foods that they view as a treatment for illness. We need to communicate ethnicity-related food intolerances and allergies to the diet staff. In regards to family patterns and gender roles, we need to communicate with and include the person who has the authority to make decisions in the family. Ask about the roles of members in the family. As far as culture and life transitions, we need to assist families as they mark rituals or rites of passage that symbolize cultural values. Common events expressed with cultural rituals are puberty, pregnancy, childbirth, dying, and death. When we're looking at repatterning or changing of one's lifestyle, we need to accommodate clients' cultural beliefs and values as much as possible. When a cultural value or behavior hinders a client's health and wellness, we need to attempt to repattern that belief to one that is compatible with health promotion. We need to plan and implement appropriate interventions with knowledge of cultural differences and respect for the client and family. For communication, we can improve nurse-client communication when cultural variations exist by establishing rapport with the client and family. We can use facility-approved interpreters when the communication barrier is significant enough to affect the exchange of information between the nurse and the client. The Joint Commission requires that interpreters should be available in healthcare facilities in the client's language. Use only a family-approved medical interpreter. Only use a facility-approved medical interpreter. Do not use the client's family or friends or a non-designated employee to interpret. Inform the interpreter about the reason for and the type of questions that will be asked, the expected response, brief or detailed, and with whom to converse. Allow time for the interpreter and the family to be introduced and become acquainted before starting the interview. Speak clearly and slowly. Avoid using metaphors. Direct the questions to the client, not to the interpreter. Observe the client's verbal and nonverbal behaviors during the conversation. Get feedback from the client throughout the conversation. Do not interrupt the interpreter, the client, or the family as they talk. If the conversation doesn't seem to go well, stop the conversation and address the situation with the interpreter. Use nonverbal communication with caution because it can have a different meaning for the client than for the nurse. Apologize if cultural traditions or beliefs are violated. Encourage the client to express their perception of the problem. Discuss the types of approach or treatment the client tried. Healers are alternate types of practitioners sought for treatment. And negotiate. Options are mutually agreed upon. We can incorporate possible alternate treatments. Collaboration should include client, family, health team members, healers, and available resources. Always consider the client's preferences for language, delivery of healthcare, diet, health beliefs, and/or treatments, and accommodate that as much as possible when providing care. Care must be respectful and effective for clients of any language or culture. This includes providing language assistance to clients who have communication needs, informing clients of language services verbally and in writing, giving the client learning materials like videos or handouts in their preferred language, and having instructional signs written in all languages common among members of the population in the area the facility serves. Use teach-back method for client instructions to determine the clarity of the nurse-to-client communication. Communicating with clients who have limited English proficiency, use gestures to increase understanding, recalling the client's nonverbal communication values. Speak slowly at normal volume, avoiding abbreviations and slang. Use layman's terminology. Determine client understanding throughout the conversation. Smiling and nodding can be demonstrations of respect, not understanding. Use printed materials suited to the client's level of understanding. Determine the client's health literacy, the extent to which an individual is capable of comprehending and processing information to make decisions regarding their health care. For example, the client has access to health information but does not understand the medical terminology. This decreases the client's likelihood of adopting scientific health practices or adhering to provider-prescribed treatment. Barriers to culturally responsive nursing care. impaired communication due to language discrepancy, culturally inappropriate tests and tools that lead to misdiagnosis, ethnic variations in drug metabolism and related to genetics, health disparities or differences in health status in one population when compared to another population. Disparities have been linked to cultural groups, including distinctions of poor health associated with lower socioeconomic status, older age, and minority status. These groups often face healthcare disparities of reduced access to healthcare and risk factors for disease. Poor access to healthcare. Low-income and middle-income groups have less accessibility to healthcare compared to high-income groups. Example, Black and Mexican American children are more likely to be hospitalized for asthma complication than non-Hispanic and white children. Discrimination. Discrimination involves unfair treatment of individuals, affecting rights and opportunities based on their association with a certain group. Prejudice involves making assumptions without full information, which often results in taking wrong actions. A nurse might assume a client does not need financial assistance and does not offer help, or assumes the client is uneducated and speak to the client in a way that is offensive. Ethnocentrism is the belief that one's culture is superior to another's. Ethnocentric ideas interfere with the provision of cultural nursing care. Spirituality can play an important role in clients' abilities to achieve balance in life, maintain health, seek health care, and deal with injury or illness. It is associated with an awareness of inner self or belief in a higher being or some connection to a purpose greater than oneself. Hope, faith, and transcendence are integral components of spirituality. Connectedness helps clients find comfort and empowerment despite life's stressors. Interpersonal connectedness is with oneself. Interpersonal connectedness is with others and the environment. Transpersonal connectedness is with an unseen higher power. Faith is a belief in something or a relationship with a higher power. Faith can be defined by a culture or a religion. Hope is a concept that includes anticipation and optimism and provides comfort during times of crises. Transcendence is the belief in a superior force beyond the person and material world. Self-transcendence is an authentic connection with the inner self. Spiritual well-being can include personal connectedness to a higher power and connection with others. When faced with healthcare issues, acute, chronic, or life-threatening illnesses, clients often find ways to cope using spiritual practices. Clients who begin to question their belief systems and are unable to find support from those belief systems can experience spiritual distress. Spiritual distress is a challenge to belief systems or spiritual well-being. It often arises as a result of catastrophic events. The client can display hopelessness and decreased interactions with others. Nursing interventions are directed at identification, restoration, and/or reconnection of clients and families to spiritual strength. Religion is a system of beliefs practiced outwardly to express one's spirituality, typically related to a particular form of worship, sect, or spiritual denomination. Spirituality might include religious practices. Religious practice can include reading sacred texts, having sacred symbols, prayer, meditation, connecting with spiritual leaders and a community of other followers, and observing holy days. Religions often dictate guidelines related to dress, diet, modesty, birth, and death, although individuals from the same religion might adhere to different practices from each other. Assessment and data collection. When collecting data about a patient for spiritual assessment, a spiritual assessment includes several components. We have the primary component, self-reflection, nurses on personal beliefs and spirituality. Initial, which is identifying the client's religion, if any, and a focused, which is ongoing as nurses identify the clients at risk for spiritual distress. Spirituality is a highly subjective area requiring the development of rapport and trust among the client, family, and provider. The nurse should screen the client for any pause in their spirituality and inquire if they would like to receive support. The nurse should ask the client about their faith or spirituality to meet their spiritual needs. Some examples of questions include, how important is your religion/faith to you? How can we support your spiritual well-being? Would you like to have someone from spiritual services visit you? The nurse can also use screening tools to gather more data about a client's spiritual needs. We can check the environment for prayer books, devotional literature, religious medals, Bible, Quran, rosary, or cross. We can observe the behavior of client, like prayer before bedtime and meals. We can pay attention to if they verbalize or speak of a higher power or God, Allah, Jehovah, or if they are depressed or angry, what is their affect and attitude in relationship to spirituality. When we assess the client, we need to assess their faith and beliefs, their perception of life and self-responsibility, their satisfaction with life, their culture, their fellowship, and the client's perceived place in the community. We need to observe rituals and practices. We need incorporation of spirituality within profession or workplace. And we need to assess client expectations for healthcare in relation to spirituality, traditional versus alternative paths like shamans, priests, or prayers. Patient-centered care. Some clients may have religious or spiritual preferences that may impact their health. It's important for the nurse to be aware of some clients' interfaith practices. The nurse should honor and respect the client's preferences. Identify the client's perception of the existence of a higher power. We should facilitate growth in the client's abilities to connect with a higher power. We should look for environmental, behavioral, or verbal clues to assess a client's spirituality, a sacred text at the bedside, a Bible, Quran, Rig Veda, praying at bedtime, or talking about God, gods, or other higher powers. Assist the client to feel connected or reconnected to a higher power. Allow time and/or resources for the practice of religious rituals. Provide privacy for prayer, meditation, or the reading of religious materials. Use facilities' pastoral care department if appropriate. Facilitate development of a positive outcome in a particular situation. Provide support for the client experiencing spiritual distress. Establish a caring presence in being with the client and family rather than merely performing tasks for them. Support all healing relationships, using a holistic approach to care, seeing the larger picture for the client, using client-identified spiritual resources and needs. We need to be aware of diet therapies included in spiritual beliefs. We need to support religious rituals like icons, statues, prayer rugs, devotional readings, or music. We need to support restorative care, including prayer, meditation, and grief work. And then evaluation of care is ongoing and continuous with a need for flexibility as the client and family process the current crisis through their spiritual identity. Look over this slide for some different examples of spiritual rituals and observances from different religious groups.